Our first speaker is Jeff Lobosky. Jeff is a skilled neurosurgeon and valued member of our medical staff for many years. He's also been involved in initiatives and public health activities on both the local and national level. I think a lot of us would be familiar, for example, with his efforts in the area of injury prevention. He has an interest in healthcare reform and has written a book on the subject, and I think he'll be kicking off the evening by talking about kind of his diagnosis of the problems of the healthcare system and some of his thoughts about potential remedies. Jeff?
Thank you, Dave. Good evening, everybody. It's a pleasure for me to be here tonight. I'm glad to be back, and I'm really honored to enjoy these other speakers and coming before you tonight and discussing healthcare. Now, I hope that I don't have to start this evening off by convincing this audience that for decades our healthcare system has been severely broken and badly in need of repair. If you want, I could repeat the litany of shortcomings that I discussed when I last spoke to all of you last July, but I really feel that's beyond what we're here for this evening. When you think about reforming a system that is as large and as cumbersome and as expensive as our system is, it seems on the surface to be a very daunting task. But I think that we can simplify this system of healthcare reform by incorporating three basic principles that I think are three basic components that I think are essential if we're going to have effective healthcare reform. Now, those three principles, as I see it anyway, are universal coverage, making sure everybody has insurance, but just as important is the second principle, universal access. It does you no good to have an insurance card if nobody will see you because the reimbursement rates are so low, or because your deductibles are so high, it prevents you from seeing a physician for well baby checks, breast exams, and the like. The third, and probably the most important component to an effective reform, is controlling costs. Now, if you paid attention in the last presidential election, all the candidates talked to us about reform, and candidate Barack Obama, I think, clearly delineated what his vision was for reforming our system. He said up front that, number one, there has to be universal coverage. Everybody has to have insurance. Number two, he said it was mandatory that everybody participate. There were no free lunches here. Everybody had to participate in this system for it to work. Third, he told us that it was about time that insurance companies stopped their policies of denying care to people because they had pre-existing conditions or rescinding that same care once they got sick and all of a sudden their illnesses became expensive. Now, the cornerstone of Obama's plan was the development of what he called a public or a government option, a public or a government insurance company that would actually compete with the for-profit insurers for those patients that found themselves increasingly being priced out of the market. In addition, he thought it was essential that Medicare be allowed to negotiate the cost of drugs, just like every other insurance company can. He told us that it was time that we stopped the fraud and abuse and waste in the system. He said it was time that we started focusing on evidence-based medicine, and it was time that we started focusing on preventative care. So we as a nation listened to the debates, and we listened to President Obama's, or candidate Obama's, vision for health care, and we elected him. He told us what he wanted to do, and we elected him. And very soon thereafter, he began in earnest trying to implement that very plan that he told us he was going to do. But no sooner had he begun that than all the special interests began to rear their ugly heads. Everybody from the pharmaceutical industry to the insurance industry to the American Medical Association to the Hospital Association and to the trial lawyers all got together and all of a sudden told us that Obama's plan was nothing more than socialized medicine, the government takeover of health care. And very soon, Obama, who came into office promising us a new day, promising us an administration of transparency found that they were doing nothing more than retreating back to those smoke-filled rooms and cutting deals with those same special interests just to make sure that a bill got passed. Now, what came out of that process was the Patient Protection and Affordable Care Act, signed into law by President Obama last spring with much fanfare. And I think what we as a nation have to decide was, is that bill going to fit those three criteria that were necessary to assure success? Well, let's look at a couple of these. Let's start with universal coverage, because I really think that this bill had the potential, and still has the potential, of providing universal coverage. What they're going to do through a variety of machinations, by the year 2014, they're going to shift almost 35 million of the 47 million uninsured people in this country into the roles of the insured. That's a good thing. They'll have insurance. Number two, this bill specifically forbids insurance companies from denying policies to people because they have a pre-existing condition. It forbids them from rescinding the care of those people once they get sick, or putting caps on the amount of care that they need. And again, this is a good thing. Third, it mandates that everybody play in the system by setting up fines for people who choose not to participate. So we can do what everybody else did at the White House that day and stand on the podium and raise our hands and say, hip, hip, hooray. We now have health care reform. Well, I'd suggest to you maybe we should not move so fast. Let's talk about universal access. As many as 20 million of the 34 or 35 million Americans who will now get health care will do so simply by lowering the eligibility requirements to the federal Medicaid system. Now, for those of you in the audience, Medicaid in California is called Medi-Cal. And I don't know how many of you tonight have a Medi-Cal card or on Medi-Cal, but I can tell you as a physician, and from listening to the many, many patients who I see in my office on Medi-Cal, that trying to get care is near impossible. Try to get a timely MRI scan, try to get a timely mammogram, try to get seen, get your operation, try to see a specialist, not only in this community, but in communities around California if you're on Medi-Cal. Good luck. You know what we do? We give them an insurance card, we give them a cap, we give them a jersey, and we tell them they're on a team. But very few of these people will ever get a chance to get into the game. Now, the other problem, as I see it, is one of the ways they propose spending for this large increase in our health care is by cutting reimbursement to both physicians and to hospitals through the federal Medicare program. Now, Medicare is the health program for our seniors. And I'm going to tell you, Medicare right now pays us doctors rather marginally. And if they cut us, as they propose, up to 23% more and more physicians are going to refuse to see Medicare patients in their offices, and those that do will severely limit the number that they can absorb. And our seniors are quickly going to find that they're in the same boat as those Medicaid patients. They've got a card, but nobody's going to see them. Now, is it possible to really achieve universal coverage? Well, I think it is. I mean, after all, there's a lot of countries across the world that do a very good job of doing so. Now, how do we do that? Well, there's a variety of options. We can do what the Republicans tell us. We can stand up and say this is the greatest health care system in the world, and all we need to do is tweak it a little bit and let the market run the show. Well, we've been trying that for 30 years, and ladies and gentlemen, that isn't working. Now, number two, we can do something drastically different, a single-payer system, and I think Hank is going to talk about that very thing later, and I'm not going to steal his thunder. From the point of view of a patient, from the point of view of cost containment, I think there's a lot of attractiveness about a single payer. However, I think there's some inherent problems in the concept of a single payer, especially in American culture. And in turn, the bottom line at the end of the day is it remains a monopoly. A monopoly. And therefore, as a physician or as a hospital, if I were a pharmaceutical representative or if I were a device manufacturer, I'd be very afraid about an entity that controls all 325 million lives. Now, we can do what President Obama told us to do and set up a government option that's going to compete for those people in the middle. Now, it's interesting, I think, that the American Medical Association strongly opposed the government option, as did the insurance industry. Now, they don't oppose the government option for our seniors, the people who are on fixed incomes and are really the big utilizers of health care resources. No, you know what? Medicare's fine for them. That public option's great. They don't oppose a public option for the poor people, for the indigent. They don't have the money to pay for these policies. You know what? Public option is just fine for them. What they do oppose is a public option that competes for those people in the middle, the people who are young, relatively healthy, mostly employed, very low utilizers of health care resources, pay their premiums or else pay them, or they're paid by their employers, because that's where all the profit is made. So it's not surprising that that gets termed socialized medicine or the government takeover of health care. Now, you can do what Dianne Feinstein had recommended, and essentially saying all insurance companies must be non-for-profit. What that would do is immediately it would return the focus to the patient and away from the investor and Wall Street, which the for-profit insurance companies have gone to. Now, I thought a reasonable alternative, as I saw this public option diminishing, was to go ahead and create a public option, stick it on the shelf, and set up benchmarks and timetables. And if those benchmarks weren't met by the timetable that was set, the public option would kick in. But that wasn't to be. So it is possible, I think, that we could achieve universal coverage. But the elephant in the room, ladies and gentlemen, is the cost. Too many people, unfortunately, feel that the end game of healthcare reform was simply making sure everybody had an insurance card, everybody had coverage. That's not the end game. That's just the start of this. That's just the start. Right now, we're spending $2.6 trillion, or almost 18% of our gross domestic product, on healthcare, more than twice as much than any of the other industrialized nations in this world. And if we continue to do so at the rate we are, in the next decade or so, we're going to see all domestic programs suffer as a result of that. Our schools, our libraries, our infrastructure, our defense. And America will begin to lose the battle for dominance in the global economy. So can we really control costs? I say, yeah, we can. And there's a variety of different ways, but because of time constraints, I'm just going to kind of focus on a couple. Let's talk about the pharmaceutical industry. As those of you who were at my talk last July, as I told you, in 1997, under pressure from the pharmaceutical lobbies, Congress lifted the restrictions on direct-to-consumer advertising for prescription drugs. Now, what was the result of this? Well, between 1997 and 2006, a mere 9 years, the average cost of a prescription drug went from $30 to $68. Our spending on pharmaceuticals went from $72 billion to almost $300 billion. And the advertising budgets of the pharmaceutical industry went from approximately $785 million to almost $5 billion in just that 9 years. So I would suggest that the very first thing we do is reinstitute the ban on direct-to-consumer advertising. There's only one other country in the entire world that allows that, and that's New Zealand. There's a reason for that. If you restrict this advertising, you will certainly see that it'll slow down this market-driven desire and drive for drugs, and it will allow these pharmaceutical companies to take that money and put it into research and development where it can really do some good. Second, it's imperative that Medicare be allowed to negotiate the cost of drugs just like every other single insurance company. They're responsible for almost 60 million lives. Look at that market strength. If they could go to the Merck and say, hey, we'd like to use your blood pressure medicine, but we're not going to pay $10 a pill, we're going to pay $6 a pill. And I've got 60 million lives if you want them. We have to let them do that. Studies have shown us that if you just let Medicare negotiate, the cost savings will be somewhere between $70 and $100 billion annually. That's almost $1 trillion over a decade. So I think that's a no-brainer. Third, we cannot allow new drugs to flood the market when they're of marginal benefit. I think the FDA should have a new law that says you are not allowed to bring a new drug to market unless you can prove that it's significantly better than what's available. Currently, the vast majority of drugs that are coming to us are nothing more than we call copycat drugs or Me Too drugs, where they simply alter one or two molecules and they simply do that to get around patents. If we told drug companies we're not going to approve those kind of drugs, what you would find is they would take that same amount of money and put it into research and development for truly, truly innovative and life-saving and life-changing drugs. Now, if you're going to do this to the pharmaceutical industry, ladies and gentlemen, you have to be fair. And I think I have no problem with us increasing the patents on pharmaceutical products up to 20 years. If they're going to put the money and the time and the effort and the personnel into creating these drugs without a guarantee at the end of the day that they're going to be successful, the very least we can do is protect them and reward them. And lastly, I think we should immunize drug companies from liability. If a drug later on, once it's on the market, is found to have a side effect that was unanticipated in the FDA studies, we should protect them. We should protect them, unless we find that there's been fraud and they knew about it before. This is how good research is done. All right. No one really knows the cost, but defensive medicine, protecting ourselves, the costs go into the billions and billions of dollars. As I said to you last summer, our current system of malpractice is a joke. It's a lottery mentality that does not protect patients from negligent doctors, nor does it protect good doctors from frivolous lawsuits. I find it very interesting that this law, which was so important, and this issue, which is so expensive, received nothing but simple lip service in this bill. Now, why was that? It shouldn't surprise anybody, because in the last presidential and congressional election cycle, the pharmaceutical industry donated $299 million. They were the largest single donor to congressional and presidential campaigns. Now, they gave about 80 to 90% of that money to Democrats. And since the Democrats wrote this bill, it should surprise none of you that there's nothing in this bill about tort reform. And the corollary is also true. It should also surprise none of you that if you ask a Republican, how do you fix health care? They say, go after the lawyers. Now, how can we do that? How can we really do good tort reform? Well, we can establish malpractice courts made up of seasoned doctors, lawyers, and judges who would review every malpractice case and determine if there was merit. And if there was, they could recommend a settlement. Now, either party involved, if they don't want to accept that settlement, they're free to take it to trial. But if they lose, they're responsible for the costs of both parties. We can do what they do now at the University of Michigan. And they have what's called apologize and compensate. What they do is if a patient has suffered an injury because of a medical mistake or negligence, the involved party, be it the physician, the nurse, the pharmacist, the medical student, actually goes to the bedside of the patient, tells them what happened, and apologizes for it. And then the institution offers them fair compensation. What that has done is resulted in amazing cost savings at the University of Michigan in their liability insurance and has markedly reduced the number of lawsuits at the University of Michigan. We should immunize doctors who practice evidence-based medicine, who are practicing with evidence-based guidelines. We're not perfect. Medicine is still an art. But if we're practicing within given guidelines and something goes wrong, I think we should be immunized from lawsuits. In addition, we have to assure that the lion's share of any malpractice judgment goes to the injured party, to the patient, and not to their lawyers and not to the courts and not to that litany of expert medical witnesses who make their living going from trial to trial to trial to testify. All of you in this room tonight, if you look around, 35 miles from wherever you sit right now, there are 5 cancer centers. We have one in Chico, there's one in Paradise, there's one in Oroville, there's one in Red Bluff, and there's one in Marysville. 5 cancer centers. We need to regionalize care. What you find is that each of these institutions builds a nice big building, They buy a lot of expensive equipment. They hire personnel to fill those buildings. And yet, they all find themselves struggling for patients. There's not enough patients to go around. That doesn't even include the marketing costs. And I'm not trying to single out the cancer centers, Dave. The same goes for the trauma centers, the heart programs, the spine centers, all of those things. We need to regionalize care. You know, evidence shows us that the more often that we do a complex procedure, the more often that we take care of a sick patient, the better we get at it. We do better, and the outcomes are better. So the savings here would not only be you don't have to duplicate services, but indeed, with lower complication rates and shorter hospital stays, there's another cost savings involved in regionalizing care. It's the right thing to do. I'm going to close by talking about what I think is the third rail of healthcare reform. And by far and away, this is called the rationing of healthcare. And I think it is the single most important thing that we can do to make sure that this system works. It's the most successful component is that we adequately ration care. Now, when I first thought about rationing healthcare, I had a very simple plan. I figured we should deny care to anybody who's older than the age of 86. The fact that my mother-in-law, Mary McLean, just turned 87 had nothing to do with that decision. Seriously, folks, rationing health care is not about establishing Obama death panels, and it's not about denying mammograms to women who need them. It's nothing more than reasonably allocating the limited and finite amount of funds that we have to the kinds of treatments that work, to the treatments that actually benefit patients. And we have to make those decisions. We can't be doing a cardiac bypass on every 95-year-old woman who comes into the emergency room with a massive heart attack and an ejection fraction of 20. By the same token, we can't be doing operations on newborn infants or 9-month-olds whose total existence is being fed by a feeding tube or through an airway and have no comprehension of their environment. We can't do that. But those extremes are rare, and most of the time those decisions are made properly. Where we're really losing the money is in the middle, in the daily things. The guy that goes on his patio over the weekend and grabs his cooler of Budweiser, and while he's taking it from one end of his patio to the other, he strains his back. He goes into his primary care doctor's office 2 days later and demands a $1,500 MRI scan. It always shows something, so he gets sent to a neurosurgeon who finds that something and recommends an operation that he can do on him. That has got to stop. Now, you know, we can kid ourselves. This doesn't mean that the 95-year-old lady can't have that bypass, or that 9-month-old who has no existence whatsoever can't get their 9th operation for their shunt failure. What it means is we don't have the revenue and the resources to pay for all of that. They have to pay for it if they want that. That has got to come into the discussion. But there's not a politician in this country who has the courage to discuss that. And we have to, as a society, do so. Don't kid yourselves, ladies and gentlemen. We've been rationing health care in this country for decades. But we do it in the cruelest and the most unfair way, based on socioeconomic status. And if you need an example, just look to our neighbors to the east, Arizona. On October 1st, the Arizona legislature passed a law that stopped doing transplants in Medicaid patients. Since that period of time, there have been 4 people who were on a waiting list for a liver transplant. Their numbers came up, but they could not go and get their transplant because they were on Medicaid and they died. We rationed them right out of the system. We rationed them right out of the system. Look, this isn't the time for all of us to sit back and to join in the partisan rantings that we've heard. Now's the time for our elected officials to really stand up and put politics aside. It's time that they work hard and diligently to craft and to create a system that works for everybody. All of us in this room, we look at America and think of ourselves as a great and a noble nation, for a good reason. Well, ladies and gentlemen, I think This is really our chance to prove it. Thank you.
Thanks, Jeff, for a very interesting and provocative talk. Your mother-in-law and I are going to want to meet you out in the alley, though, afterwards.